You are preparing to operate on a patient with type 2 diabetes and high cardiovascular risk. The clinical demand here is twofold. You need to maintain tight glycemic control while simultaneously protecting the patient's heart and kidneys from the acute stress of the procedure. To meet this standard of care, we will build a complete operational mastery of empagliflozin, detailing the prescribing algorithms, its longevity mechanisms, and the strict safety protocols required for clinical use. Empagliflozin delivers comprehensive perioperative safety and long-term metabolic health. This diagram illustrates active renal elimination at the proximal tubule. This is exactly where empagliflozin blocks the SGLT2 transporters, preventing glucose from being reabsorbed back into the bloodstream. This schematic maps the transport of those ions and molecules. By inhibiting this pathway, glucose, sodium, and water are diverted from the peritubular plasma straight into the urine. You can remember this mechanism with the acronym SGLT, sugar loss through toilet. This mechanism operates completely differently from metformin, which acts on the liver to decrease hepatic gluconeogenesis. While metformin limits the internal production of excess glucose, empagliflozin actively drains it away through the kidneys. When we look at geroprotective molecules, compounds like NAD and rapamycin target cellular senescence. Empagliflozin acts on a different pathway, specifically addressing organ-level oxidative stress in the cardiovascular and renal systems. Because empagliflozin forces the continuous excretion of glucose, it shifts the heart's primary fuel source from glucose to fatty acids. This metabolic shift reduces tissue inflammation and improves the overall mechanical efficiency of the heart. This comparison matrix plots empagliflozin, metformin, and rapamycin against cardiovascular mortality and renal decline metrics. By forcing metabolic flexibility, empagliflozin drives lower cardiovascular mortality and preserves kidney function. This branching flowchart maps the clinical decision tree for initiating empagliflozin based on comorbidities. Path A is monotherapy, selected for metformin intolerance or targeted protection in heart failure. Path B utilizes Synjardy, joining empagliflozin and metformin, maximizing glycemic control by pairing hepatic and renal blockades. There is a hard stop for severe renal impairment. If the patient's estimated glomerular filtration rate, or eGFR, is below 30, prescribing this drug is strictly prohibited. This algorithm prioritizes long-term organ protection ahead of simple A1C reduction, ensuring the patient's heart and kidneys are guarded first. Before clearing any patient for an invasive surgical or dental procedure, you must execute a rapid 4-point chart review. Step 1. Check renal function. Verify that the current eGFR is above 45 for optimal safety. An eGFR of 30 is the absolute minimum clearance required to proceed. Step 2. Screen for medication conflicts. Check their chart for the concurrent use of loop diuretics. Combining these with empagliflozin heavily compounds the risk of severe volume depletion. Step 3. Screen for euglycemic diabetic ketoacidosis. Be aware that these patients can be in life-threatening ketoacidosis even if their blood glucose monitor reads as entirely normal. Step 4. Establish the fasting protocol. Instruct your patient to suspend their empagliflozin dose for a full 3 days prior to surgery to avoid a metabolic crisis while fasting. Running this precise checklist isolates invisible risks, like euglycemic DKA, before they trigger an emergency in your operatory. Moving to the clinical chair, the diuresis caused by empagliflozin creates specific oral health implications. Patients are highly susceptible to xerostomia, or dry mouth, and face a higher risk of developing oral candidiasis. To mitigate this drug-induced dehydration, provide the patient with water immediately before the appointment, and mandate frequent hydration breaks during long procedures. Volume depletion also severely increases the risk of orthostatic hypotension when moving the patient from a supine to a standing position. To prevent patient syncope, you must initiate the 3-step chair adjustment protocol at the end of your procedure. Step 1. Elevate the chair back to 45 degrees. Pause the patient in this position for a full 30 seconds to allow their blood pressure to stabilize. This schematic shows Step 2. Elevate the chair to 90 degrees. Have the patient swing their legs over the side of the chair and pause for another 60 seconds. Step 3. Assist the patient to a standing position. Keep your hands ready and ensure they are completely steady before you release support. Executing these physical steps with precision guarantees a safe outcome, matching the strict care you applied to their pharmaceutical dosing. Returning to our high-risk diabetic patient, they have successfully completed their procedure and are standing safely on their feet. We achieved this success by making a clean prescribing decision between monotherapy and combination regimens based on their specific comorbidities. Next, we executed a strict pre-op assessment, verifying renal function, screening for DKA, and holding the medication for 3 days. Finally, we applied the 3-step chairside protocol to safely manage their volume-depleted orthostatic risk. By fully integrating these advanced protocols into your practice, you deliver safe surgical outcomes while practicing high-level geroprotective medicine.